Okay, good morning, everybody. We're going to go ahead and get started. I know we're filtering, I think, from the IDEO Design Challenge, but my name is Kevin Clausen. I'm from Lipscomb University in Nashville, Tennessee, and I'm very happy to be here today to introduce each of the four speakers for the session on health and human behavior today. First up, we have Dr. John Hixson, who's an assistant professor of neurology at UCSF and the San Francisco VA, where he also serves as associate chief of staff for the clinical informatics, which I love hearing and seeing those sorts of departments and titles grow in the area. Today, Dr. Hixson will be sharing some of his work based on using a digital platform in veterans with epilepsy.
All right, can everyone hear me okay? Okay, so for about the next 15 minutes, we'll be talking about a study that we conducted within the VA healthcare system over the past 2 years, called the POEM study. And as was already mentioned, I'm from up the road at UCSF and the San Francisco VA Medical Center. So our agenda for the 15 minutes is that I'll talk a little bit about the background of the condition that we focused on, which is epilepsy in the VA system. And then I'll show you a little bit about the design and conduct of the study. We'll go into the results, and then we'll talk about the discussions of outcomes and value. So epilepsy in the U.S. veteran population, perhaps not unsurprisingly, is a serious issue. We know that traumatic brain injury is a major risk factor for the development of epilepsy later in life. This data here is actually from the Vietnam era, demonstrating that there's an up to 20% risk, even multiple decades out from a penetrating head injury. You'll notice that this is for severe injury. What we don't know is that if the veterans that are now returning from these most recent Middle East conflicts will also have risk, because most of their injuries are in the moderate to mild area, the concussive blasts. But we actually don't know whether there's this looming epidemic of epilepsy in the VA. So that's something that the VA is very interested in studying, and that's part of the reason why we did this study. So the actual name of the study was the Policy for Optimal Epilepsy Management, which is just a nice short name to call it. And we really leveraged the epilepsy centers of excellence. There are 16 centers across the United States that all capture up to 20,000 veterans that we have a known diagnosis of epilepsy. And that was very attractive to us because it obviously led us to a nice little niche of patients that we could easily recruit from. So we partnered with Patients Like Me. This is one of the logos that they have on their front of their website. If you don't know, Patients Like Me is a fairly well-known and now mature online platform that really encourages patients to share their data and then learn from others. And their engagement cycle is just briefly shown here. Basically, they create a health profile that they then share, and they put in characteristics, and then they have a search tool that they use to identify others, quote, like them. And then they will add data about their health condition, which I'll show you a little bit about. And then that data is aggregated, anonymized, and then presented back to the patient. And I'll show you some examples of that. And then the idea is that the patient would be able to then track that information and use it to become more empowered. And the question is, how do we demonstrate the value of that empowerment? Right? That's the real trick. And then play an integral role in their own health. So here's these are actually a little older screenshots. If you go to the Patients Like Me website now, it looks a little different than this, but the basic idea is the same. So similar to what you'd see on other social media sites, an individual can create a unique profile with a little avatar picture, name, background that is all publicly available to other people on the platform. There's a little widget here that shows that is intended to show in a very quick manner the different types of conditions that a patient has. And then here's, again, one of the older views for the tracking tools. So these are data points that were entered individually on individual days. Down here is our seizure meter. And you can see this is a little bit of an exaggerated, hopefully exaggerated, because this is demonstrating that this person is basically having a seizure every day. But every time a person logs a seizure, you can categorize it by type and frequency. And then patients also update their treatments and side effects, symptoms, which they can log over here. And then all of this data, again, is aggregated and then presented back to the patient. If a patient is, say, on a drug called Keppra, which is one of the more common epilepsy drugs, they can say, okay, how many other people on the platform are on Keppra, and what types of side effects are they having? And then hopefully they'll learn from that. So they may not have recognized that something that they were experiencing since they started Keppra was actually a side effect. they now realize that that's likely the case, and they can go back to their physician to have a conversation about that. As you may all know, there's a robust forum, and this is really where the conversation happens, and that's an important part of the Patients Like Me platform as well. They also, because it's online and it's a management platform, you can use what are called PROs, so patient-reported outcomes, and this is really how we designed our study. We delivered validated surveys that have been used in the epilepsy literature as our outcomes, and so patients, when they logged on, they would complete these surveys, and that's what we used as our metric. So our hypothesis was that the use of this online social media platform would result in improved epilepsy care as measured by these so-called self-efficacy metrics. So, at the beginning of the study, we thought, okay, should we see if participation in this platform will lead people to have, say, better seizure control? And we thought that was a little audacious, because that's making a number of assumptions that could be false, okay? What we're really hoping to show is that patients participate in this platform and then learn from others to better manage their own condition. And if that's true, then one could probably use that to generate a hypothesis that they may have better control of their condition. So we, again, included U.S. veterans who had been diagnosed. Again, we used that network to get our patient population, and then we employed a very robust recruitment strategy throughout that population. We had patients enter the site digitally and do their consent online, and then we had them complete 2 of the PROs at baseline, and then after 6 weeks of participation, and there was a modest incentive for completion of the entire study. So the 2 scales that we used are called the Epilepsy Self-Efficacy Scale and the Epilepsy Self-Management Scale, and these are probably not well known to you, but they are highly used in the epilepsy space. Typically, they are a secondary outcome in traditional pharmaceutical trials, and I'll talk a little bit about what these are. Basically, these are 2 studies, 2 validated scales that were developed in the early 90s that intend to show basically how well a patient understands what they need to do to manage themselves at home. And so they're asking questions like, I keep track of the side effects of my seizure medication, or I have a support group of people who have epilepsy, or when my seizure medication is running out, I take less medication each time. This is actually an inverse answer. So there's a variety of inverse scores so that patients don't learn how to take the test. And then it's all scored on a Likert scale system, so a 1 to 10 type scale. So there's 2. One is called the Epilepsy Self-Management Scale, and this is actually measuring how often people report that they actually do the behavior, okay? As opposed to the Self-Efficacy Scale, which is intended to know whether people know what they're supposed to be doing. Now, they may sound very similar, but these instruments have been validated separately, and they have been shown in the literature to measure different things. You could imagine it's essentially, do you go on a 4-mile walk every day because you know it's good for your health, or do you know you should go on a 4-mile walk every day because those are 2 different types of knowledge that you're looking at. So we use both of these. Now, there are subscales within each. The one that we were most interested in was the subscale called Information Management, which essentially assesses a patient's ability to use online platforms for tracking, communicating with others, collecting information about their side effects, adverse events that they take back to their physician. We collected, because it's an online platform, you actually are able to collect a robust amount of data regarding demographics, utilization, that would include logins, forum posts, comments, new friends. Basically, we got permission through the informed consent to track these people, everything they did on the platform. So here are the results. We, over the course of about 6 months, recruited 249 eligible participants. 92 of those individuals completed both surveys. So that means that they completed the 6-week course and then took the second survey. These individuals all took the first survey, and some of them continued to participate but ultimately didn't complete the second survey. The average age was 50. They were 81% male, 75% non-Hispanic white, which is actually quite consistent with the overall veteran population. We had somewhat wondered at the beginning of the study whether we wouldn't disproportionately capture patients who are returning from Iraq and Afghanistan, the younger population, but interestingly, this is actually spot on the demographic for the overall VA population. So I think one of the sub-lessons we learned here is that this is actually a very accessible platform for even an older demographic that might not be a so-called self-motivated patient. This slide on its own doesn't mean a whole lot. This is basically the baseline scores. And again, this is a Likert scale for the self-management survey, scored on a scale of 0 actually to 10. You'll just have to take my word for it that the baseline is actually very consistent with the validated norms that were established back in the 90s. So this is just to say that we're not dealing with a population who started out differently than the average. And if you'll note, the scoring, the lower the number, the worse people score on this. Information management, which is self-reported use of online tools, scores the least. And that's actually consistent not only in the veteran population, but in the general population too. The same thing for the epilepsy self-efficacy scale. Again, this was all consistent with the general population. So the results show that there was an improvement really across the board for both of the co-primary outcomes. So the self-management score improvement, this is the one that actually asks how well a person actually does the behaviors. So not knowledge of what they should do, but what do they actually do. And there was only a marginal improvement, although it did have a very nice statistical significance, going from a raw score of 3.7 to 3.9. Self-efficacy score also improved with a significant p-value. And again, this is the survey that actually tests whether people know what they're supposed to be doing independent of whether they actually employ the behavior. Now, the biggest improvement was, as we expected, in the information management subscale, which showed a 17% improvement with a very high statistically significant p-value. And again, this is really asking people questions about whether they are able to adequately use an online platform for tracking their medications, tracking adherence, tracking side effects. In terms of the utilization statistics, the median number of logins, again, among people who completed the entire study was 5, meaning that they logged in on average about once a week. As you might imagine, there was a pretty wide range, with some people not logging in at all, basically just taking the 2 surveys, which presumably you would expect that they would have actually dampened the overall effect because they had no change. And some people reporting up to 80, so there were super users in the group. 15% posted to the forum publicly. 10% left a profile comment. That means they went to another individual's page and left a specific comment for that other member of the community, as opposed to the public forum. But this would actually be publicly viewed, but it was just on the other person's profile. 30% sent a private message to another member of the community, and that would be, that's pretty intuitive. That's not something that the public would be able to view. 26% reported that they met a new person with epilepsy, and 10% considered these people to be, quote, friends. So what now? Again, this was a validated outcome. This was something that we thought about a lot. How would we measure this? We didn't want to use just a proprietary survey that said, this was great, we loved it. We wanted to use something that had already been accepted in the epilepsy community to give validity to it. But nonetheless, it's still considered, as you might imagine, a soft measure. So if you look at traditional epilepsy studies, they really focus on, the big hits. Do we reduce overall seizure burden? But when you talk to an epilepsy patient, yes, they want to have their seizures controlled, but that's not the entirety of what's causing them to have poor quality of life. There are many other elements. So we hypothesize that this is the first step to developing a way of assessing these types of platforms, which may have an impact on the other things that are bothering a person in terms of their quality of life. But there's no direct path to implementation for these currently, and there's a limited incentive structure, as you all know. And this is in contrast to the typical pharma or device studies, which use a very hard, well-established measure, and there's a very clear path to implementation with a known incentive structure. So personally, I think that this is where you take the results of these studies and you say, what now? You can publish this, but ultimately, how do you implement it? For instance, if you ask epilepsy patients, this is not just about stopping their seizures. This is about returning them to socialization, allowing them to drive, allowing them to return to working productive status. And then you can also look at other more traditional metrics like healthcare utilization. Does it decrease their emergency services use? Does it increase their utilization of pharmacies so that they're not as having problems with medication adherence? And does it do a better job of limiting the amount of psychological support services that they may need? So these are some of the things that we're working on now in terms of taking the study to its next step. I think that the results, although positive, are really a first step, and in my opinion, a good way to develop a hypothesis such that we may use some of these outcome measures to drive our next study design. So I'll wrap up by just saying that digital health platforms can and should be evaluated with academic rigor. I'm seeing more and more of this at meetings like this, and that makes me very happy. I think that clinicians and investigators should not shy away from recruiting the non-tracker. We had a lot of trepidation going into this because these veterans are not self-starters, if I can generalize. These are not people who found patients like me on their own, which is what the bulk of their current platform consists of. And yet we got reasonable participation, and in a population demographic that you really wouldn't have expected. I would say that trials with typical patients in a very practical, non-controlled setting, I would highlight that we didn't call these people every week and say, please participate, right? We asked them if they wanted to join, they did, and then we left them alone. So this is definitely a real-world experience. And then policymakers and stakeholders need to seriously consider alternative metrics for health success. And that really gets at some of the last comments I made. And I'll close up there and take any questions. Thanks. Right. Right, so we really did not. Well, so I'm going to qualify that. We ran a pilot 2 summers ago to, because we didn't want to make any assumptions. And so we took about 25 participants and sat in the room with them as they were navigating the platform. And what we found is that probably because these aren't self-starters, your regular kind of tracker patients, that it wasn't immediately intuitive what benefit they could derive from the site. So then for the main study, what we did add, which I think is relevant to your question, is shortly after they went through the online consent process and then completed the 2 survey metrics that I detailed, they were immediately dumped into a landing page that is not there for your normal patients like me patient. And it was a very simple page, but it basically demonstrated the different areas that could potentially provide value. So that included the epilepsy veterans specific forum, the tracking tools, some educational materials that were on the site, which I didn't go into detail here. So it was a bit of a unique experience for members of the patient population, but just for that immediate kind of dump into the system. After that, they were free to do whatever they want. There was no coercion. There was no this is what you need to be doing. We wanted it to be a real world practical experience. Sure. Yeah. So, right. So I believe that this is your classic statistical significance versus clinical significance story, right? And this is, for anyone in the medical area, probably everybody in the audience knows that you can run a study and the science behind the study is intended to show, did your intervention actually have a direct impact on the metric change? Right? So you want to ensure that you're not just dealing with a statistical chance thing, okay? So what this shows is that the intervention that we employed clearly caused the improvement. So for the information management and the others, the p-values were very low. But you could argue that the effect size was not high enough for it to be clinically meaningful, right? And that's true. I mean, I want to be the person with the scientific rigor here. That is true. I don't want to say anything too controversial, but if you look at other treatment modalities that we currently support within our health ecosystem, the bar is relatively low for clinical improvement. It is, even in the pharmaceutical realm. So, this is a non-traditional metric. I mean, it's up to all of us to determine whether we think that effect size is meaningful. I think for me, this is more a first step, right? So it's showing that there's a definite impact here. And, we like a lot of studies, this is really a driver for more hypothesis generation. Yeah.
to explore that group?
So we have done some subgroup analyses, which I obviously didn't present here. I would say that our super user group was, as you might expect, relatively low, probably 10% of the overall population. Some of the characteristics, so the overall demographic characteristics actually really didn't show any correlation with multiple analyses. Not unsurprisingly, we showed that people who completed the study participated a lot more than people who didn't complete the study, right? So I remember I said there were 92 completers, and then there were, 100 and whatever, 50 people. Those 150 other people participated, but participated less. Somewhat surprisingly, there wasn't a skew in patients who were, say, more educated or more working. No, I mean, it was pretty similar across. We have now looked at some data, after the study ended to see how many people hung around. Our numbers actually look pretty good. I'm not going to go into the details, but similarly, we also found that people who fully completed the study tend to hang around longer than people who didn't. I mean, pretty intuitive stuff. Right. So we did do subgroup analyses on multiple associations. So, whether people who, communicated with another person through, say, a profile comment or a private message, used, the search tool more to look up treatment effects. And, we didn't find any other associations. It could just be that our numbers are too low, right? So we started this as your classic textbook scientific study where we said, we're going to power the study to look for a change in these specific primary outcomes, the two that I listed. We put it on clinicaltrials.gov. That's what we targeted. And then all of the other data, as you probably all know, you can look for associations. But if you didn't power your study for that, just because you don't find an association doesn't mean it doesn't exist. It may just mean that you needed, 1,000 patients to accurately test that association.